different types of tympanograms. Which shape of tympanogram is seen in which condition is a favorite topic of the examiner doctor. This is a normal type of tympanogram. Typically it will be peaked in appearance and flat type. Where do you get? It is flat. Whenever there is any non-functioning tube with the middle ear effusion, then you get a flat type. Then if there is any negative pressure, then it will take a dip down, and that is typically seen with a poor Eustachian function, tube function associated with a serous otitis media type C is what you typically see. So this is a normal type of a tympanogram. This is how it looks like with a peaking up. Then you have a flat type with a middle ear effusion, impacted wax or a total perforation, and with a negative going down, that is a Eustachian tube dysfunction. That's what you typically come across. What is this red beefy lesion on the tongue classically? There are two things that can cause it. One is geographic tongue is a reddish lesion, and a median rhomboid glossitis also is typically a red lesion, is what you have to basically appreciate. With regard to the wax in the ear, how do you do syringing? Will you hit up or lower wall of the meatus? So you don't hit along the lower wall of the meatus, rather upper wall of the meatus is the one which you will be hitting. Now, with regard to the spasmodic dysphonia, spasmodic dysphonia is a neurological issue. There can be hypereduction or abduction. Botulinum toxin is the one which is used. So, adductor spasmodic dysphonia, patients will talk with a strained, strangled voice and very harsh. Whereas abductor spasmodic dysphonia, the voice becomes breathy. That's a classical way by which the quality of voice you can decide whether it is adductor or abductor type of spasmodic dysphonia. Now, with regard to the child who has a difficulty in swallowing his own saliva, you are able to see the peritonsillar abscess. So, there will be a foul breath, hot potato voice, shifting of the uvula to opposite side, and there is a unilateral severe pain. So, these are all the features. So, what is this lesion protruding out? This is a anthracoinal polyp is what you need to remember. So, it starts like an edema, and it comes via the accessory ostium, and it will lead to a unilateral nasal obstruction. They are all the true facts about anthracoinal polyp. There are another 7-8 very high yield points frequently asked in the NEET PG exam about the anthracoinal polyp, which is one of the top hot topics. I am very happy to see 22 plus online viewers. So, now, aortic stenosis. Why does the angina occur? Angina doesn't occur because of a fixed blood flow. Why does angina occur? I mean, not to the coronaries. I'll explain you. Typically, the aorta arises from the left ventricle, and coronaries arise at the start of the aorta. Whenever you are exerted, you need to increase your cardiac output. But if there is any fixed aortic stenosis, when you are exercising, the cardiac output doesn't increase commensurately. Because of that, there is a decreased perfusion into the coronaries. So, it is not fixed output into the coronaries, but fixed output from the aorta into the aorta is the reason for the development of the exertional angina, which is the very characteristic feature of the aortic stenosis is what you have to basically remember. You have ejection systolic murmur radiating towards the neck. and there can be a left ventricular hypertrophy, and in spite of exercise where you are expecting an increase in cardiac output, that doesn't happen, and that lead to exertional dyspnea, exertional syncope. All events happening with exertion is the hallmark of the aortic stenosis, is what you need to remember. Whenever organophosphor poisoning patient comes to you, you will do resuscitation, put him on ventilator, everything is over. But there can be a delayed polyneuropathy which can happen, and that will stop the recovery, and it involves both sensory and motor type of polyneuropathy, and usually why it is called delayed? It takes about 2 to 3 months of time before its onset, hence called delayed, is what you need to appreciate. MELD score क्या है? Child puke score क्या है? Child puke score, you have encephalopathy, ascites, bilirubin, albumin, INR, they are the components. Whereas MELD score, you have bilirubin and INR and creatinine. Then MELD sodium means what? Bilirubin, INR, creatinine and sodium. Then you have 5V MELD. That means bilirubin and INR, creatinine, sodium and albumin is called 5V MELD. Now with regard to healthcare facility, hospital associated pneumonia, which pneumonia is treated to be hospital acquired? Unless the patient is there for more than 48 hours admitted, then only that pneumonia is ascribed to be a hospital associated pneumonia. And at least 2 days in the last 90 days, if there was a acute care hospitalization, then only you can accuse the hospital to be associated with that pneumonia of the person, is what you need to remember. You have a potato